Good morning, colleagues. You are welcome in the oncological teaching chair. Oncology is a very interesting discipline which has connection to all of the medical specialty, also to the stomatologists. We have only 2 lectures. In 2 lectures, it is impossible to give you all the material with which you can have contact in your future professional life. But I shall speak with you about those problems that are obligate for all physicians despite of the specialty. I understand that mostly of you will be the stomatologist. You will cure the teeth, but you will also observe the lips. You can observe the tongue. You can observe the mucus of oral cavity, and that is very important. And I wanted, I think that you remember from the past teaching chairs about the significance of early diagnosis and the correct treating. And so the first lecture for the future stomatologist, I shall begin with an extravagant observation, my own observation. I should evoke in your mind a kind of shock and make you remember about the role and the responsibility of the stomatologist for the fate of his patient. I hope you remember from the former teaching chairs 2 very important principal things. First, malignant tumor, cancer, is curable when early diagnosed. And the second, the morphological verification is the most important criterion in cancer diagnostic. And so let us begin. That's my observation that I have promised to you, with which I will begin our lecture to evoke a kind of shock in your mind. Now be careful. A young man was addressed to the dentist with a toothache. The doctor inspected his oral cavity and decided that the dolor came from the 8th right upper tooth, so-called wisdom tooth. As it is used in dentistry, the wisdom tooth is an unnecessary rudiment, and it was removed. The removed tooth was thrown away without any morphological investigation. It is the first mistake. You would, the wound after tooth extraction closed unsatisfactory. It was bleeding, suppurating, the granulation appeared in the wound. The patient visited the dentist several times, but without any results. At last, after nearly 2 months of observation and futile treatment, so-called treatment, the granulation tissue was sent to the morphological laboratorium and received the result of the investigation. The result was unexpected for doctor. It was cancer. The patient was directed to our clinic, to the oncological clinic, and the full clinical investigation was performed. The diagnosis, our diagnosis, sounded squamous cell carcinoma of the maxillary sinus, so-called hymory cavity, T3 and XM0G3. It means that it is a local advanced tumor. The surgical method of treatment was chosen as the optimal, and the right maxilla resection was carried out. It is a big operation. The current treatment of such tumors consists of an en bloc excision of tumor in combination with full-dose radiation therapy. During the operation, it must be recognized that the reasonable expectation of local controemergence must be histologically free of tumor. To reach such a result, in our case, there was necessary to perform maxillectomy. It is a total procedure, including partial orbital resection, the orbital resection. This was a very large and traumatic operation, and with unsatisfactory cosmetic result. The patient lost his right eyesight after post-operative irradiation. It means that he was unable to see on this eye. Despite all performed intensive treatment, the tumor continued to infiltrate the neighboring tissues toward the basic cranium, and after 2 years of tortured life, the patient died. It is very sad. Who is to blame in this case? The first sign of the hymory cavity tumor is a toothache. It means that the tumor is located on the down plate of maxilla. In this stage, the effective treatment was possible. The tumor was irritated by the action of dentists many times during 3 months without specific treatment. I underline that there was used no specific treatment, from the dentist. No chemotherapy, no radiation, no radical operation, only the irritation of the tumor. It means that the tumor was irritated and began to grow more quickly. This could evoke a stimulated growth of the tumor, which resulted in the late and very traumatic operation. I ask you to remember this case and follow the Latin adverb in dubio recipienza. What that means? Remember, when you doubt, think about the cancer. The cancer is a very often disease, and it can be in every localization, in your localization, the stomatological localization too. And now let us make a short review of the head and neck oncology, the region of your future activity. The field of interest of the stomatologist belongs only to a part of the head and neck region. There are the main areas of upper aerodigestive tract, namely the upper and lower lips, the oral cavity, partially salivary glands, the skin of the face, and cervical lymph nodes are to be added to this list. The oral cavity extends from the skin vermilion junction to the lips of the lips to the junction of the hard and soft palate above and the line of circumvallance papilla below to it divided into specific areas included the lip, buccal mucosa, lower and upper alveolar trigos, retromolar gingiva, retromolar trigone, the floor of the mouth, hard plate, and anterior two-thirds of tongue. Not all tongue belongs to the oral cavity, only the anterior two-thirds of tongue. The floor of the mouth, the main rows of the drainage from the oral cavity are into the first station of cervical lymph nodes. Cancer of maxillary sinus, which we have mentioned in our case report, is the most common paranasal sinus tumor. As you have seen from these case reports, stomatologists can meet with a tumor located on the down plate of the hymory cavum, which usually demonstrates itself with toothache. Tumors of the head and neck account for about 4% of the overall incidence of cancer. The most important risk factors of oral tumors are tobacco and alcohol. Ultraviolet radiation, it means sunbeams, remains the main risk factor for facial skin. The genetic factors can play a role in the head and neck cancers morbidity, the presence of Bloom syndrome, Lee-Frankman syndrome, Plummer-Wilson syndrome. The face skin cancer belongs to the so-called visual localization. All the localization of cancer will divide to the visual localization and to the internal cancer. For instance, pancreas cancer is the internal cancer. You aren't able to observe it with your eyes, but the tooth, the mucous of oral cavity, the tongue, the lips, they are visual localization. That means that without any machines, any apparatus, you can see those tumors. Therefore, the diagnosis of this localization has to be relatively easy. Despite this, only 1/3 of the patient present at the early stage and half of the patients present with local advanced diseases. With improved local regional control and long-term follow-up, approximately 20% of patients develop distant metastases. You see, the visual localization, 1/3 of them are diagnosed in the late stage. And that's why our treatment possibilities are limited. Common symptoms in patients with cancer oral cavity include a painful ulceration, slurred speech, bleeding in the oral cavity, and exophytic mass. The diagnosis of oral cancer is occasionally made on routine examination by a dentist or a stomatologist or oral surgeon. Advanced tumor of the oral cavity may extend to the skin and subcutaneous tissue, complicate but orocutaneous fistulas. Now, let us make some remarks of the general view about this problem. First, usually we speak about at the beginning, we speak about the epidemiology of this localization. What does it mean, epidemiology? It means how many cancers in different countries of this localization are under observation of the doctors. The incidence in center countries such as Sri Lanka, India, Pakistan, Bangladesh, oral cancer is the most common cancer. Incidence rates is more than 20 per 100,000 population in male. In parts of India, oral cancer can represent more than 50% of all cancers. In developed countries, oral cancer is less common, but is the 8th most common form for the cancer. The death rate, the highest death rate per 100,000 population are in Hungary. It means 9. In Slovakia, 9 and 5. The lowest death rates in male are in Chile and Venezuela. It means less as 40 per 100,000. Inspection of age-specific mortality rates reveals substantial increases at younger ages in most countries. The role of the race, incidence of tongue cancer consistently is found to be higher in blacks compared to the whites. The sex males are affected more frequently than the females. The age. Oral cancer predominantly is a disease found in middle-aged and older persons. About the etiology. The causes. I have already mentioned that tobacco and alcohol are independent risk factors for mouth and tongue cancer. The combined effect of alcohol and tobacco is greater than the sum of two effects independently. Cigarette smoking compared to not smokers, the risk of oral cancer in smokers is of low medium tar cigarette was 8-fold, and for high tar cigarette was greater than 16-fold. Tobacco chewing in people from parts of Asia appears to predispose the oral cancer, particularly when it is started early in life and is used frequently and for prolonged period. Marijuana use has been implicated also to the cause factors. The alcohol. Alcohol beverage may contain cancerogens and procancerogens, including nitrosamine, urotan, contamin, and ethanol. The combined effect of tobacco use and alcohol consumption are found to be multiplicated. Compared to the non-drinkers, the non-smokers, the risk of oral cancer is increased 80-fold in those with the highest level of smoking and alcohol consumption. No specific for the Asia, battle chewing and similar habits, battle quit chewing and oral snuff are important risk factors in people from specific geographic areas. The battle chewing in Southern Asia. The battle quid contains a variety of ingredients, betel wine leaf, betel nuts, catechum, and often sage thyme tongue with tobacco. Some chew that not only and other prefer pin, which induce tobacco and sometimes lime of catechum. Battle quit chewing is an important risk factor, and the area battle, not habit, with or without tobacco use can be the cause of cytogenetic changes in oral epithelium. Diets low of fresh beta-carotene rich vegetables and fruit may also be predisposed to oral cancer. I've several times visit India, and I observed even the children that have that use the drawing of battle. They have such a specific red lips and tongue, which you can see when they are laughing or speaking. The next is oral health. Poor dentition, as reflected by missing teeth, emergent as a strong risk factor independently of the other establishing risk factors. Mouthwash use. Mouthwash use is a risk factor in a small subgroup of non-smoking, non-drinking women. Socioeconomic status. Behaviors leading to social instability and/or social instability itself are likely to an increased risk for oral cancer. And at the end, the infective agent, Candida albicans, and viruses such as a herpes virus and papillomavirus may be implicated in some cases. The pathophysiology. Cancerogene metabolizing enzymes are implicated in some patients. Alcohol dehydrogenase, ethanol and acetaldehyde, which is cytotoxic and results in the production of free radical and DNA hydroxyphilic bases, alcohol dehydrogenase type 3 genotype appears the predisposition to the oral cancer. DNA repairs gene are clearly involved in the pathogenesis of some rare cancers, such as you can see the xeroderma pigmentosum, but more recently, evidence of detective DNA therapy has also been found to underline some oral cancers. Immune defects may predispose to the oral cancer, especially to the lip cancers. The pathologic evaluation. I have told you that the histological diagnosis is the most important method of diagnostic of every cancer, and no diagnosis is possible. No diagnosis is possible without a histological examination. And the most common sites of oral cancer include the lower lips, the lateral margin of the tongue, and the floor of mouth. However, all areas should be to some areas or coffin corner of the posterior tongue floor, the mouth of the common site of the cancer, but may be missed by cursory. It is the general remarks about the general remarks about the oral cancer. In the second lecture, I shall speak with you about the concrete diagnostic and treatment, and to meet you in the clinic, in our clinical training. Every group will come to me also for the clinical training, and I shall have the possibility to show you some patients and so on.